We can play that again at 8. Let everyone come in. So we got we got 20 people already ready to go.
But they haven't, they can't see or hear us yet, right?
Yes, they can. We are live.
Oh, and I was just going to put some more lipstick on. How exciting. I can still do that, guys.
You can. You can turn your camera off and do it, or I don't think they mind.
You know, everybody, everything was better when you have a good lipstick on.
So we got about 4 minutes before we officially get started. So let us know where you're from. This is going to be a very, very interesting topic tonight. I'm very proud of Alicia. She pulled all of this together herself, a whole course that can actually help practices earn more income for work they're already doing. Oh, we have a New Jersey.
I was just about to say, I love seeing where everybody's from. So please feel free.
I don't want to butcher her name though. Shanaz and Anna from Alaska. Wow.
Wasilla. Anna is a frequent flyer with us, if I remember right.
Well, welcome, welcome.
And Darcy, another Darcy. We have a Darcy instructor on the other side of the United States from you in Florida.
Yeah, we got a lot of people from Central and West Coast.
Drew's,
well, I'm representing the East Coast from Florida. I'm getting over bronchitis, and my eyes are all puffy and red, so I did not want to come on camera. So, but Alicia's doing the presentation. I'm just here to be her Vanna White. Oh, we got it, Florida. Catherine. Yeah. Pembroke Pines. I did a presentation down there long ago.
And
Arkansas and Texas.
My Texas peeps. I know lots and lots of people in Texas. What part of Texas? Nick McDealum.
Never heard of that.
Yeah, that's a unique and exotic name. Yeah. Arkansas, Miami Beach. Bet that's pretty over there. So I'm coming to you live from the Ozarks of Missouri. Stone Mountain, Georgia. I bet Chevette has a beautiful accent, a beautiful voice. Dallas, that's where my daughter's at. In Bethel, Alaska. Yay, Alaska.
I was just watching some videos. My dream is when I retire, I want to have a RV and me and my husband go around the country. And so I was watching this one gentleman, Trent the Traveler, and he just does really good videos, and he's been going in Alaska. And I said, wow, I did not realize how beautiful it is there. So that's going to be on my bucket list.
Yeah. In the summer and in the spring when everything starts to green up. I've never been to Alaska, but I have a lot of friends that have lived in Alaska, and they send beautiful pictures. And my father's cousin was a game trapper up there, and he had a picture one time he brought back of a bobcat that had, I guess it was a bobcat. It was bigger than a bobcat that we'd have down here, that they netted, that had gotten into the, jumped into the water, and it was all in the net, and it was like, and its teeth and its claws. And I thought, wow, that's a massive animal. And it was wet. It was not happy. Neat. Atlanta, Indiana.
So tonight we have one CEU for those that are attending live and are in the StreamYard room. You can be watching on YouTube, LinkedIn, Facebook, but to get the CEU credit, you need to be logged in to the StreamYard. So I'll put the link up again. And at the end, we will put the password in the chat only. And you'll see where to go do your 1-question quiz to get your CEU. And of course, for our club members, you can watch it anytime in the club and watch it at your own pace with all the handouts and get your CEU that way. So that's the benefit of being a club member.
Yeah.
So I'll find the link. So if people are on through YouTube or LinkedIn or whatever, but they want to get the CEU credit, they can go register and, just have that open as on a separate tab. That's the proof for the AAPC and for QPro that their people attended live.
Mm-hmm.
So I'll let you go ahead and take it away, Alicia, and I'll be here as you need.
Right. So we are right on the hour. Perfect timing. As many of you know, we have a new code that is going to benefit both the provider or clinician as well as the patient population that they're taking care of. This, as Laureen mentioned, for some of you guys that were here a little bit earlier, this is services that many are already giving to their patient population. However, they've never really been reimbursed for it at the level that they're going to be able to do that now. So it's a win-win situation, both for the medical professional as well as the patient population that they're taking care of. And we're going to go over some of the steps that will be able to help you utilize this code. In addition, we're going to talk about what that would look like in your facility or office, how you'd be able to utilize this code. And just briefly, we're going to highlight a course that we offer to people that already have a medical background that are wanting to get certified to be able to implement and use this code. Not anybody can do the work for the utilization of this code. It states very clearly that the person needs to be trained. The topic, again, train your staff to provide patient illness navigation and get paid for it. So I'm going to jump right in here and let's talk about what our QPIN credential is. Ultimately, it was developed due to the need that we saw. We started getting clinic systems, health systems would contact us at CCO and say, we want information on using this new code G0023. Can you do a lecture? Can you provide more information? And we said, of course we can. We can do that. That's what we're known for, right? Education. However, once we started talking to them, we realized they may not truly understand what the G0023 entails and the requirements for it. So we rounded back with them and said, from what we're hearing, we don't think that maybe you're going to be utilizing this correctly. And if that's the case, one of the things we do know about new codes that increase revenue is that it becomes a red flag to OIG and those auditors that are, as I like to say, paid to find mistakes. So we want to make sure that you are not only trained to use the code, but the people that are going to provide the service within your clinic is properly trained. Ultimately, the goal is to have a patient-centered care and the ability to manage serious high-risk conditions. That's why the G0023 was created. We're going to look at how you're going to address the increasing demand for comprehensive illness navigation in healthcare practices. We developed the course and the credential for Qualified Patient Illness Navigator so that not only are you providing this service, but you can show and prove that the personnel you have implementing this service is properly trained. Let's first understand what patient illness navigation is actually and what the services that can be provided to your patients. It's a comprehensive care, and we are going to be addressing serious high risk conditions. Now, if a patient has a new diagnosis of hypertension, that's probably not a patient that you're going to offer this patient illness navigation for. If you have a patient that has comorbidities and a new diagnosis of hypertension, along with, say, the development of kidney disease, now that's different, right? So we have to look at the whole picture of the patient. One of the areas that we look at is the condition chronic? Because that's the goal. This is not an acute scenario. Say a person falls and breaks their hip. Okay, that fracture is not the indication for patient illness navigation services. However, if the patient has severe osteoporosis, and it's causing these complications like fractures, and the patient's had recent falls, then that's different. So we have to make sure that the diagnosis that we're using to implement these services for the patient is the true diagnosis. This could not be the acute diagnosis. However, what was the uh, slow burn, as I guess we would say? What's the disease process that developed this acute problem? When we look at that, then from the standpoint of chronic conditions, now the provider gets to state what's chronic and not chronic. But for this code, the description states that the patient would have the condition for at least 3 months. And that's a good kind of mainstream understanding of chronic. Also, they're looking for risk factors. Within those risk factors, are they at risk for hospitalization? Are they at risk for having nursing home placement? Maybe they have an acute exacerbation of a condition. So they have COPD, but now they have an acute exacerbation, and it's that COPD is getting into the emphysema or side effects of that. In addition, it could be functional decline of the patient. The role of patient illness navigator is to improve patient outcomes. How are they going to do that? It's, in my opinion, kind of a threefold process. One, you're a liaison. Now, you are not the provider, the clinician. Uh, Instead, you're the communicator that brings the patient and the clinician together. In addition, I consider this role as a patient advocate. You're going to be able to talk to the patient and maybe get some of their questions answered, or not necessarily answered, or find out what their true questions are. When a patient doesn't feel good, when they get a new diagnosis or an exacerbation, or they really get the news that this disease process has developed, they're not always in the right mindset to get their questions answered properly, or can't even think of the questions that they might have until after they go home and start thinking about it, and dwelling on it. So you don't get a lot of opportunities to see the clinician. This allows you to tap in to a person, the patient illness navigator, to say, hey, I've got some questions. I didn't get a chance to answer them. Are you able to connect me to the provider? Or do you have resources for me that I can answer these questions? Or are these even valid questions that I have? So there's this affirmation that you're able to provide to that patient that, yes, absolutely, these are valid questions. And you're an information source to them that the provider gave you a handout, but that might have been a little intimidating to see all of that paperwork. Maybe you'd like to see a video on how to manage this particular condition, that that type of visual education is more beneficial. So we'll get that to you. Things like that. So again, you're a liaison, you're a patient advocate, and you're an information source for the patient. On top of all of that, we are allowed to bill for the code. This is a HCPCS code. It is G0023, and then there's an add-on code to that for an additional 30 minutes. Let's talk about the description. The description is incredibly long. If you go into your encoder and you put in G0023, it is a page of scrolling to get all of the information. So what we've done is we've kind of just chipped away at that content and outlined it for you. I'm a big proponent of outlining. I think it makes it easier to manage when you have intense content that you need to go through. So the description, the highlights are, this is a monthly code. It is time-based, and it's all done on reporting not only the time, but you're also showing the services by an auxiliary personnel. This is not going to be the nurse. Now, I'm not saying it can't be the nurse, but this isn't usually the clinician. And when I say clinician, I'm saying the doctor, the nurse, the LPN, or the nurse practitioner. Again, this is an auxiliary person. This may be a perfect patient illness navigator would be the MA. Excellent. A CNA would be absolutely brilliant at this as well. So again, a person that has a little bit of a medical background so they can articulate as well as document. We'll get to that in a moment though. Eligibility and requirements. This is something that you just don't do at a whim. The patient is picked by the physician or the practitioner, and there's going to be oversight by that practitioner of the documentation and the care that's given or services that are provided from the PIN. On top of that, you have to document it. So this isn't just doodling out notes on a card. Best practice is to have a template. And we created the QPIN course and gave examples of templates that you might want to adapt to your practice. Now, again, that is exclusive for our QPIN students, but we'll tell you more about that in a moment. The document requirements are that we have to have the care plans. We also have to have documented the time that's spent with the patient and the outcome. I have a pet peeve with documentation, a couple of them, but one of them is the outcome. And I don't think that we see that enough in the documentation. What's the expected outcome? What is the plan if the expected outcome doesn't come to fruition? You know, what is our plan A and plan B? But in the meantime, what's the outcome? We need to chart that. So think of this as somebody that has the ability to chart. They need to be able to document. And there is a proper way to document in a medical record. This will be included in the patient's medical record. So you have to be careful what is documented, that it's documented clearly, and that it's done in a professional manner. And therefore, it's always helpful to have somebody that has a little bit of experience reading documentation, familiar with it, and not somebody that doesn't have any background. It can be learned, but you sure don't want to have something documented that isn't professional. The reimbursement opportunities. One thing we have to do first is we have to make sure that we're compliant, or you're not going to get reimbursed. And to get the full payment that's allowed, you have to have these steps in place: the care plan, the time that's spent, and the outcome of the service that's being provided. I wanted to also let you know that this is not patient monitoring. That is a completely different area. A lot of services or codes are classified as monitoring a patient. That is not what this is. In fact, we're not taking a patient's vital signs. We're not doing an E&M, and we aren't necessarily taking the patient's entire problem list. This is not going to look like an office visit encounter or a sick visit encounter. In addition, auxiliary person can do this, or a peer support specialist, which we'll mention next. And this is a true medical document that will be filled out and put in the patient's chart. So that also means that it can be reviewed by people that are doing auditing for you. So what are the roles and responsibilities? Now that we kind of have highlighted uh, what this service is, to how we would implement this and put this in place, what do we need to do to train a staff member to be able to do this? Again, I mentioned great people that would do well in this position are LPNs, MAs, CNAs, somebody in the office that is familiar with reading documentation and has the ability to document properly. It can be learned, though. The roles and responsibilities: the care navigators, they're going to manage the care plans provided by with patient support. Now, they are not coming up with a plan of care. That's why they do not have to be a clinician. The provider, the doctor, or the nurse practitioner, they are coming up with a plan of care. What you're doing is you're managing the patient's ability to follow along the plan of care. And again, this isn't classified as monitoring, but it can take doesn't have to be an hour in one setting. You can check back with the patient multiple times. Say it's 10 minutes every week to confirm that the patient is still uh, without questions, or if they do, getting those questions to the provider so that you can relay answers to those questions. Also, just if they are able to maintain the steps that have been put in place for their treatment. We'll get into more detail with that in a minute. But let's talk about what a peer support specialist is. Many of you may not realize what that is. And the patient illness navigation, let's do a little history real quick. Historically, that has been utilized in cancer patients. Because as you know, that is usually a minimum of a year's course of treatment. And there's a lot of players involved, a lot of different providers, especially depending on what type of cancer that the patient has. On top of that, oncologists, and then radiology, and the pharmacology, all involved in the patient's care. And it can get pretty intimidating. And on top of that, the patient doesn't feel good, and the family is usually intimidated, or have a little bit of that medical illiteracy where they're not sure what's going on and may not feel comfortable asking until things go downhill. And then we want to not have those panic sessions. The patients can be very informed. So that's why a peer support specialist has always been really good in this role. Again, going back to historically, breast cancer. Having a patient that has had breast cancer and survived it and come out on the other side, they're an excellent candidate for this role because they can relate to the patient. They can articulate their fears and what to expect with some of the outcomes and let them truly feel like the patient's being heard. And again, when you come up with some of these specialists like cancer, you don't really get that face to face time with your doctor often. And you get these little windows, and then you feel like you're left hanging. We don't want that to happen. So, individuals who have been successfully through a specific disease, but it doesn't have to be cancer alone. It could involve mental or substance abuse problems. Again, similar experiences. That if that's your specialty, behavioral health, someone that's come out on the other side would make an excellent um, PIN. We want to think outside the box. Training your staff, again, we're going to look at the key skills and knowledge areas that you're going to want to work on. Patient communication and empathy would be the number 2 thing after the ability to document, in my opinion. So if you don't have a person that could document, that can be learned. It's not always easy to learn to communicate or have empathy. That is a skill that usually comes with wisdom and time. So, a patient illness navigator may be a person that is a little bit older, a clinician that is no longer active in practice and is just able to perform, just would like to be able to still benefit patients, but they can't be out there on the floor anymore, trudging in the trenches, or as some of them do. But empathy and patient communication, again, it can be learned. But in my opinion, again, this comes with people who have had experience that leads into that peer support. What are we looking for? We're looking for someone who can give validation to the patient, acknowledging the feelings that the patient has, that they're being heard. How many times have you had a person or a family member that is not feeling well, and over a long period of time, because we're talking about chronic conditions here, and they just want the doctors to find out what's wrong with them, I'm not going crazy, my knee hurts, even though they've scanned and they've done XYZ, and they keep saying that there's no reason for my knee to hurt, and yet I can't walk up the stairs without pain, things like that. Empathy, demonstrating genuine care and compassion for the patient's struggles. This is not the same as sympathy. Empathy is different. Reassurance, letting the patient know that there is a solution and that you're going to help them see the light at the end of the tunnel and hopefully relieve that anxiety. I know firsthand with family members that sometimes they feel worse, or their blood pressure goes up, or the pain gets worse because of the anxiety of the unknown. And that's what a lot of these chronic conditions are, especially if they have an acute exacerbation. Am I going to be living like this for the rest of my life? So reassurance, collaboration, in addition, encouraging the patient that uh, that they are an active participant in their care. I think that's where patient advocate comes in to play. That everybody has a different personality type. Doctors and often have one personality type. For the most part, they're type A people. And They're on a tight schedule. They have burdens. And so reassuring the patient that they are a part of their care, not just the provider saying, okay, we're going to give you this medicine and I want you to do ABC and come back and see me in a month. Okay, that doesn't feel like they got to participate in making choices about the medication that they're on and their plan of care. Positivity, concluding with optimism, always letting the patient feel empowered. These are key components of a person that's going to be successful as a uh, patient illness navigator. Also, knowledge of condition specific care plans. Now, if you do not know terminology and anatomy, then this is going to be difficult for you. If you have someone in your practice that you're thinking, oh, I think that, uh, Betty is going to be perfect for this role. And she has the empathy. She has, been through a chronic condition, but she doesn't understand the anatomy and terminology. So that when I write a plan of care, she's not going to understand and be able to articulate um, it to the patient or be able to bring back questions. Pharmacology and pathophysiology. Those three areas I think are going to be necessary for a person that's going to take on this role. Now, do they have to be an expert? Absolutely not. And do they have to be a clinician? No, they don't. When we look at peer specialists, a lot of times, some of the people, when I was teaching coding at a college, the students that did the best were the ones that either had a chronic condition in a family member or themselves. They were the best because they picked up on the terminology, the pharmacology aspect, and the pathophysiology. Also, familiarity with documentation. I already mentioned this. uh, Legal document, and we can use templates and you can fill in the blanks on the template, but you still have to understand how a template works and the basics of medical documentation. I'm so thankful that I got to start in the medical field before I was 18 and that I got to be an EMT at 18 because that truly taught me what to document because we wrote all of that out by hand. And I had some great mentors that taught me how to document properly things to say like the patient stated, little nuances like that. So again, that's very, very important. So let's take a pause and say, I've got somebody in mind, but I don't know that they have all the skills they need to really provide this service in my practice. Therefore, what you're going to want to do is get them educated. And luckily, you're at the right place because not only did we develop the QPIN credential to supplement education that was needed for the use of G0023, but we already have these other ancillary courses in place. So you can take our course for the QPIN, and it's a fast track. It's pretty straightforward. However, I would say that it isn't straightforward unless somebody has a little bit of background. We created it for people, as an example, that were MAs in the office because they would make excellent QPINs. Now, we have a pharmacology course, we have a pathophysiology, and we have medical terminology and anatomy. If you had to pick these besides the QPIN course, I would say medical terminology and anatomy is number one, pathophysiology is number two, pharmacology is number three. That's how I would tier it. All of these courses are ancillary courses, so you could get through them pretty quickly. But to provide this service at the highest level and have less hiccups, I think it's important to have a properly trained person. We want to know that when you get ready to implement this service, that you have your person in mind that's educated and ready to go. One of the ways that you can do that to find out how they are in their skill set is do some role playing for patient interactions. It's never a bad idea to come up with scenarios. Don't think of it necessarily as an interview, but sit down and discuss how you would walk through the process for a patient that needed the service. And on top of that, you're going to want to make sure that you have supervision, not just in the beginning, but set it up that there is a supervisor for this service, and you're constantly doing performance feedback. It is not, when we say auditing, a lot of people cringe, but it's a good thing. It's a positive thing. And you want to be audited often. You want to be able to question and be questioned so that you know you're doing your job well. You'll grow, and so will the people in your team. The certification and competency assessment, make sure that you have that in place. I like to think of that as a compliance component, to where we say, these are the skills that I want somebody to have in this role. And then this is how we're going to test them to see where they benchmark at. And then this is where we're going to round back after we're in the trenches providing this service to monitor and make sure that we continue to offer the service at the highest ability that we're able to, because again, we are looking at increased revenue for your practice, but on top of that, ultimately what we're looking is to improve patient satisfaction. Some training strategies that are going to be beneficial to you. Now, there's a lot of different ways that you can do this, but these are the ones that I came up with that I feel will be the most impactful. And the first thing is that role playing exercise. I have done this. It feels kind of funny and awkward in the beginning. However, it puts you in a situation where you have to think on your feet. So it would be a good idea to have scenarios that different people in the team have experienced or that you suspect will cross their path. You could get a fishbowl, literally a fishbowl, and have your QPINs draw out a scenario, and then how would they address it? Give them the template and fill it out as if they had asked questions and responses of what they expect, and then round back and critique that and give feedback, as well as have one person pretend to be the one giving, being the patient, and the other one being in the role, and vice versa. Um, this also covers all different specialties. I see some questions coming in, and I will answer those in just a moment. That's a really good question, by the way. So provide feedback, and not just can they document properly, but their tone, their language, their emotional validation. Again, these are learned skills. Where better to learn them than on the job with the feedback from your team and your peers. There is also another area that's called EVE, or EVE framework. I really like this one too, because it teaches you to empathize, validate, and encourage. And this is something that could be a best practice just in your everyday life. One, empathize. You're going to acknowledge the patient's feelings and express understanding. Not only are you doing that verbally, but you've got to document that. You've got to have the ability to document this these conversations, as well as validate, reinforce that their feelings are normal and important, because again, sometimes they just want to be heard, and encourage, offer positive steps and support for their situation. Active listening practice. Train staff to listen without interrupting or jumping to conclusions. I do both of these. It's my personality. I have had to work incredibly hard, and I still fail frequently on my ability to actively listen. My brain runs 90 miles an hour, and especially when it's an area that I'm excited about or passionate about. So I have to train myself, and I do this often, to listen without interrupting. If I'm singing in a group of people, they don't need to hear my voice. And if I can't take it, I've trained myself to have a notepad or piece of paper, and I start jotting down my thoughts. Even if we're just talking about cooking recipes. Again, to not monopolize and jump in on the conversation, because I'm a talker. Also, you're going to learn to be reflective listening. Uh, you're going to learn to use a reflective listening technique where you make the statements. What I hear you saying is, or it sounds like you're feeling. This is a way to validate that the patient is being heard. This is absolutely something that has been studied. There's different ways you can learn to do this. I follow a lot of groups that teach you how to do this, but it is important to practice active listening and reflective listening techniques. I'm going to pause for a second and answer Catherine's question. For behavioral health specialists, specifically in autism services, are there prereq courses or knowledge needed to pass the QPIN course? For example, are the test questions pharmacology and pathophysiology? They are not, Catherine. Uh, Instead, what is the majority of the QPIN course is learning how to provide the service, learning how to document, and learning some of these skills and practicing these skills. Because Catherine, what they're going to do is when they work in your your practice, then you're training them on the specifics. So again, the provider sets the plan of care, and the patient illness navigator needs to understand the medications that are used, not mess up the verbiage and how to articulate the name of a medication. They need to be able to speak with authority and not come across as flaky or unintelligent. However, that part of it is not taught in the QPIN course. What medication would be used for autism? What medication would be used for epilepsy? Or what medication would be used for COPD? Instead, they look at it and they see that, okay, this patient has chronic migraines. Now they're on rizitrapan. You know, think stuff like that. Learning how to spell that, and that can all be done in a cheat sheet. Now, before I move on, though, Catherine, I do want you to know that if you don't feel comfortable or feel like you have the ability to train in addition, the QPIN course, and you want your QPIN person to have additional knowledge, we can gear that knowledge for them. We can help them get up to par for your standards in your clinic. But the QPIN course itself is not disease specific. I hope that answers your question. All right, now we're going to talk about some more helpful tips. Emotional intelligence training. You're going to teach the staff to recognize and manage their own emotions during difficult conversations while responding appropriately. So if you have a patient that has a new diagnosis of cancer, and then they're telling you that they're the caregiver for their spouse who has a chronic condition and hasn't been able to work, and they have small children, and you can just see and they just hit a deer and their car is out of commission. You can just see how this is overwhelming. You can't fall apart and be a hot mess over that. However, you can empathize with them. You can shed some tears with them if you need to. But that is not your role. You are not a social worker. You are not their therapist. You're not their clinician or doctor. Your role is to help them feel validated and heard and take notes of their fears and concerns and get them to the right person. So it sounds like that scenario I just gave you, they would benefit from having a social worker uh, to be able to tap into to see if there's additional services that would be helpful to them. And therefore, you would go back to the provider and you would say, we met, and these are the patient's concerns. These are all the things that are going on in their life, which are some social determinations of health. And then the provider would tell the next steps of what they want to do. Or you could, if you mention that to the patient, that there might be some services that would be beneficial to you, and you mention having a social worker contact them, they might, oh, guards go up. No, social worker, bid bad, take your children away type thing. Absolutely not. You would ease their fears and say, this is who we have in that role. I can tap you into these services. Let me talk to, Dr. Feelgood over here and let him know your concerns, and we'll keep the communication open and we'll see if we can't get you the right resources. So you're that liaison between all of these different clinicians and providers with maintaining your emotional health. Documentation of empathy and care, that's going to include the patient's concerns and solutions to the care notes, and showing a holistic approach. Again, if that scenario that I just gave you and the patient has a fear of social worker, or say that they have a fear of what type of food they're going to eat because they know that they've got to maintain a certain diet with their new diagnosis, and yet you have a family member that's just been diagnosed with alpha gal where they can't have any mammals and they're feeling overwhelmed. You know what? We've got a dietitian. Let me get you in contact with the dietitian, and or put that on your plan of care to talk to your provider to see if that's going to help you, and validate that these are good concerns, and your provider's going to want to know this, and we can add that to your plan of care. Again, you're not a provider, but you're giving them the resources and validating them. Case studies. Come up with case studies like I just told you. If you are having problems coming up with case studies, let us know, because I'm telling you, I'm full of it. I can give you a lot of scenarios and the appropriate reactions that you should have. Ongoing feedback and assessment. When you're working with this patient, this G0023 is a monthly code. And so you're going to spend up to 60 minutes or 90 minutes in a month with a patient, making sure they don't slip through the cracks. And that needs to be documented in a template that you've chosen or you've created, or you can use one of ours, and that it allows you to give that service to that patient that they're probably not going to get anywhere else, because most people don't have a patient advocate or liaison on their side. Uh, Regularly observe the cases that you've gone through, that you're working on. In my opinion, it might be a good idea to have more than one QPIN in your office, and that once a week or once a month you come together with your cases and you review them, and then what has worked, what doesn't seem to be working, and again, pull in the compliance department. Do we need to change our template? Do we need to change the tone that we're using for this diagnosis? Or is there something that we could help, or that the provider is recognizing as a concern? Or these are really good questions that you're getting from the patient for the provider, and so therefore they want to add them to the template, so that, hey, I want you to ask all of my patients that have a new COPD diagnosis or a new diabetes diagnosis? These questions, because I don't want them, as I said before, to slip through the cracks, or I want them to feel validated, or I never thought that this was going to be a concern for this particular patient. And so that means it's most likely a concern for everybody. So it really is a teamwork and getting everybody on the same page. Let's look through some scenarios. Now, these are examples. I'm excited about these that show you how it works. And this information is going to be documented. So not only do you have to be able to learn to talk like this and as well as get that information documented. The first one, a patient is with cancer is worried about the side effects of the treatment. Don't I know it? My mother had cancer, and she had breast cancer. So not only are they worried about losing their hair, but they know that everybody knows that a patient going through chemo is going to be puking a lot, have good days and bad days. They are, can they get out in public? Do they have to stay kind of quarantined and at home because their immune system is down? And also, some of the side effects that they may not realize is that, again, your immune system goes down, but you can get things like my mother ended up getting thrush in her mouth after the first treatment. She'd never had thrush in her life, so things like that. Empathy, or well, acknowledging the patient's emotions. It's completely normal to feel this way. You're facing a diagnosis and treatment like this, and it's incredibly challenging, both physically and emotionally. And then the empathy part of it. You've already shown so much strength just by coming this far. Let's focus on how we can make this process more manageable for you. Providing a solution, because that's also your role. One of our goals is to make sure that you have the support you need, whether that's talking with your doctor about managing the side effects, setting up a schedule for rest, or finding ways to stay positive. And I know with my mother, she would get her treatment. The first day after treatment, she still felt really, really good. The second day, Third day, incredibly sick. Fourth day, little bit better. Fifth day, light at the end of the tunnel. And then, and so in that week, there was a flow that she recognized. Encouraging collaboration. Let's work together to create a care plan that balances your treatment with ways to improve your quality of life. You don't have to go through this alone. How perfect is that, right? In addition, we've got another one, a patient with behavioral health concerns expressing feelings of hopelessness. The patient states, I feel like nothing I do helps. No matter how hard I try, I can't get out of this hole I'm in. And then that acknowledging and validating feelings by the QPIN. It sounds like you've been carrying a heavy burden for a while, and I want you to know that your feelings are valid. And again, it would be these scenarios that I talked about earlier. Have these scenarios written down and other ways to phrase them and come up with concerns that you've heard that patients have, and write out statements for you to be able to express to the patient. Providing encouragement. Oh, wait, no, empathy. You're not alone in this, and there's no shaming needing support. Many people face challenges like this, and we're here to help you find a way forward. Providing encouragement. Even small steps can make a big difference over time. The fact that you're opening up about how you feel is a huge step, and it shows your strength. This can be used for the cancer patient, right? You can come up with a lot of scenarios where these words are encouraging. Next steps. Let's talk about strategies that can help, whether it's connecting you with a counselor, exploring medication options with your doctor, or just building a daily routine that feels manageable. Third scenario, and this is our last scenario. A caregiver expresses burnout while supporting a loved one. Again, we're not just talking about the patient. We're talking about the team taking care of the patient, meaning the spouse or an adult taking care of their elderly parent. So the caregiver, I'm doing everything I can to take care of my mom. Excuse me, but I feel like I'm at a breaking point. I don't know how much more I can handle. So acknowledging the burden, caring for someone you love is one of the hardest things anyone can do. It's normal to feel overwhelmed, especially when you're giving so much of yourself. So the empathy, you've been an incredible support to your mother, and it's okay to admit when you need help. uh, you're not alone in this. And that's a big part of it, making sure they feel like they're not alone. Offering support. Let's look at resources to lighten your load, whether it's respite care, connecting you with a support group, or finding services that can help take part of her care over. Reassurance. Taking care of yourself is just as important as taking care of your mother. By making sure you're supported, you'll be able to keep being the amazing caregiver that you are. All right, we have some questions, so let me just breeze through them real quick because they are so good. The
Actually, I
provider,
think your next slide might.
I was going to say, I think that one's going to cover a lot of these, isn't
Yeah,
it?
go ahead and finish. You only got 2 more
Okay,
slides, and
okay.
then we'll do the
So
questions.
implementing these services, how are we going to integrate the workflow? This is, again, it's great if you got the perfect person in mind to take over this role and you're looking at the additional income that's coming in, but you got to implement it. And so this is how you're going to do it. You're going to find the person that you've picked for this role. You're going to assign the responsibilities to that auxiliary person. You're going to streamline the communication between the care team and the supervising physicians. Don't forget, the provider is the lead here, and the provider is signing off on all of this documentation and the support that is being done for their patients. The documentation best practices, always remember, this is a time-based code. Number one, if you don't have the time documented, you're not going to get reimbursed for it. So that means that you need to learn how to make those statements. Now, if it's really beneficial now that we've gone to E&M, that's medical decision making and time, because there's a lot of time templates out there, and we can help you with that documentation too, because we've got those in the background, and we can morph them to fit your practice. But you're going to want to make sure that everybody can communicate. Recording the time spent, updating care plans and medication regimes. If the care plan changes, then that has to be updated and has to be reflected in the documentation so that everybody sees it. How is that going to be implemented? How are you going to do that? Come up with an internal workflow that states that the provider is going to set up this patient for QPIN services, and that there's going to be like an initial intake. The QPIN is going to read the documentation of the provider, the plan of care. Is there highlights of what the provider wants to be covered? Then they're going to communicate, do the initial intake, and then set up a schedule to follow up with the patient, whatever works best. And after that, you're going to round back, give the provider an update, or the provider's, the doctor's nurse, however you deem it appropriate, and then keep that communication circle going so that when the month ends, you can do a roundtable and make sure that the services are being offered at the most impactful in the most impactful way. Addressing common challenges. How are you going to manage complex cases? If you think, well, I've got an hour over a month, that's not much time. But if you've got a complex case like the one that I mentioned before, where the patient has a new diagnosis of cancer, they're already a caregiver, they have young children, they've got some economic things that they have to worry about, that's pretty complex. Or maybe there's a lot of players in the game, whereas there's a lot of extended family members that are trying to help out and stuff. And ensuring consistent patient follow-ups, really, really key. if you're going to set it up that you're going to spend, 10 minutes every week with that patient in a phone call, or you're going to have a Zoom, however you're going to communicate with that patient, that's all documented, that the plan is I'm going to meet with them every Monday at 12 o'clock. And we expect to spend 5 to 10 minutes discussing the plan of care, and are they meeting their goals, do they have any concerns, et cetera, et cetera, et cetera. And then document all of that and stick with it. You've got to be diligent. Maximizing reimbursement. So let's talk money. The billing tips: accurate time tracking and reporting. If you don't have time documented, you're not going to get reimbursed for it. Detailed documentation to support the claim. How are you actually providing this service? And then supervision requirements. This is an auxiliary personnel position. The general supervision is done by the provider or providers. Do case study examples. Come up with examples of how you've been able to implement the code and how the reimbursement has been coming in. Track it, see if there's any hiccups or any problems, and put that in your compliance notebook so that you have a plan to overcome any practices that might be a problem, or things that might come up. And then when they do, or they surprise you, you have a team already in place and a workflow to take care of those challenges as they come up. Now, this reimbursement, keep in mind that this is based off zip code. And I'm not even going to tell you the zip code, because your zip code is going to be a little bit different. Kind of the contracts that you have are going to be different with the different payers, but this is going to give you kind of the eagle eye view of what the possibilities are. So again, these are G codes. Predominantly Medicare is what we're dealing with. And one of the other things that I want to talk to you about is that when you start dropping some of these codes, some of the patients have copays, and there will be some out-of-pocket expenses for the patient. You better let them know ahead of time, because some Medicare patients are used to being able to come in, there's little to no copay and no out-of-pocket expense. For the most part, there isn't, but it just really depends if they're participating or non-participating. And so again, it has to do with the contracts, the billing aspect. You're going to need to come up with that information ahead of time. Make a list of who the most common providers or payers are and your patient population. When you go to pick a patient to get these services, know ahead of time what you're going to expect. What's the payer? How much am I going to expect to get reimbursed for the work that's being done? Is that payer given any feedback or pushback on this code? Is there something specific they want? Do they want the 1500 form filled out in a certain way? Are they going to require documentation to be sent to them, especially as this is a new code being implemented? For the most part, I have not seen a lot of pushback. It seems to be going very, very smoothly for everybody. However, that doesn't mean it's not going to have problems in the future. Compliance and quality assurance as we wrap up. Staying updated on the regulations. This is a brand new code for this year, and that means that OIG and all the powers that be will scrutinize it. It's been implemented. You want to make sure that you don't have any reason for them to second guess that this code is not being used properly in your practice. So that's why compliance notebook, have templates, practice how you're going to work with your patients, and the documentation. Don't get somebody in there that doesn't have that isn't used to reading documentation or isn't a good team player. Auditing and review internal audits for billing accuracy. You're going to do regular reviews of care plans and documentation. Got to do that. If you got sloppy documentation, It's not going to pass the muster, not going to pass the review. Patient satisfaction is a metric. Get feedback from the patient. Is this a service that's been beneficial to you? What could we have done better? Do you have suggestions for us? Was it extremely helpful? How was it helpful? What do you think that we could do to make it more helpful for people that have scenarios like yours or situations like yours? And then that feedback, again, really important. But the true call to action here is training, proper training, implementing the PIN services, and optimizing the reimbursement of the G0023. All right. If you want to train somebody in your office, you've already got somebody in mind, then I would suggest that you look into our course for the QPIN. It's pretty straightforward, easy to navigate through, and it's an enjoyable course. It was really fun to put together. The basic description for G0023 under the direction of a physician, see how that all comes into play, or other practitioner, including a patient navigator, 60 minutes per month, calendar month, in the following activities: person-centered assessment, perform to better understand the individual context of the serious risk, high risk condition. And it goes on and on and on after that, several pages. Here's the link to be able to look at that course. And if you have any topics that you want us to talk about, let us know. You can get us at cco.us/topics-request. But let's answer your questions. I'm going to go ahead and put that back there as we go back. What was the provider fee schedule for this service? Let me see here. Fee evaluation right there. Again, it is different for different areas, but feel free to check in our forums. You can ask us. We have the ability to show you how to look that up for your area, specific to your area. Next question was, has anyone had success adding this code to an already in-network fee schedule with with any of the major commercial carriers? Yes, they have. And we have a practice that has been actively using it. They're a practice that came to us that wanted to get more training on this. We can reach out to them and get you some feedback on they are a family practice, but they also offer additional services. They expand. And I know, Catherine, yours is specific behavioral health. Any other questions? Is the fee schedule dependent on the advocate performing the service? I'm not sure I understand. Are you saying is the fee schedule dependent on the advocate? Yes, but the fee schedule is, if you're saying the dollar amount, no. I'm not sure that I quite understand the component of your
So,
question.
Jacqueline, if you can maybe rephrase your question,
Mhm.
that would be great, and we'll try again. Here's another one.
I don't want to misunderstand. Is there currently a limit of how many times this code can be billed per client within a certain global authorization period, or current approvals or successful claim finalization? Okay, you can bill it monthly. There is no limit on how many times in a year it can be billed, but I can tell you that it's the max is 90 minutes in a month, because then the G0023 is 60 minutes, and then there's a 30-minute add-on code, G0024. So you get up to 90 minutes every month, so that's 90 minutes times 12. Again, it is a monthly and per year.
Great.
Now, that being said, though, I would highlight that in your documentation, you better prove that the outcome and the plan is working and how it's being implemented, and any changes in the plan of care, because that slips through the cracks. As the CDI work I do, that we, what's your plan, what's your concern, and do you have a plan B? What do you expect to have a positive outcome? What are these negative outcomes that could occur? And how did that change your plan of care? So the plan of care, I project, if it is consistent every month for 12 months, that's a red flag in my opinion, because the plan of care isn't perfect. Let's see. Thank you so much. Game changer. Yes, it is for advocates. And these patients often slip through the cracks, right? It is this that it's one thing to get reimbursed. That's great. That's wonderful. But really the bigger picture here is that ultimately you're providing a better patient care and the better outcome for your patient population, not just in behavioral health and not just for cancer patients who've had this in the past. Now it's busted out to where anybody with a chronic condition can get that additional care. It's affordable now for the clinicians, the providers to offer these services. And sometimes patients, I mean, it's a real thing to have white coat hypertension. So you can imagine, I mean, there's a code for it, right? So I imagine, or in fact, I don't imagine, I know for a fact that patients really don't understand when they're given a diagnosis and a plan of care after they walk out of that office. They're awestruck by the provider. They're overwhelmed. They may be frustrated. And who follows up with them? You're not going to get that farmer who only comes in when his finger's been chopped off to articulate or talk to somebody in the office. But if they have a designated person as their coordinator for their plan of care, they're going to feel comfortable with that person and open up with what their fears are when something's working or not working. Can this course be used for CPC renewal through AAPC? I'm newly certified and still learning. It CPC renewal, do you mean does it
No,
offer
it's
CEUs? I was
you
going to say
you
no.
can use like CEUs like this about QPIN toward your, AAPC, CEUs that you're adding up throughout the year. But this is a separate certification, and currently we are the only ones we know of that has this certification. So,
That is true. And on top of that, if you're a CPCI, you could use this as teaching units. Yeah.
mhm.
But uh, could you use this in other areas to show that you're giving additional training to yourself? There are other reasons to do it, but the AAPC is not going to recognize this as anything to go with the CPC uh, because, quite honestly, we'll be frank, we can't afford to give it CEUs for the course. It's just too expensive. So maybe that'll change, or maybe there'll be something that you want us to come in and change to educate, like uh, what is it called when Laureen, when you do it in a weekend boot camp? We
Yep,
could
boot
do
camp.
we could do a QPIN boot camp for your office and work out a deal with coming up with CEUs or something like that. But again, no, but what we're doing tonight's worth of CEU, but we had
This
to.
is a resume enhancer.
Yeah,
You get this and
that's a good way to look at it.
you're
Yeah,
gonna
yeah,
help your practice that you work for. And for CEUs, just join the club. It's like
yeah.
24 bucks a month and you get all the CEUs you need. And you get, this is like one of them where we do once a month. We're now getting sponsors. Find a Code
Yeah.
have been sponsoring us. They're talking to us now. They want to do more of that where they're paying the outrageously high fee, in my opinion. It's like $330 for one CEU. Um, so, that starts to add up when you want to do like an 8 CEU event or something like that. So,
Mhm.
yeah, if you join the club, you'll get access to all of these great webinars that we do, and you'll have plenty to
And
maintain your credentials.
we're thinking there's two groups of people that are interested in this service. One, like Laureen mentioned, people who want to be trained or feel that they're a good fit to be able to provide this service and add this credential. Uh, because they have that background and they want to enhance their resume and make them themselves more marketable. And the other group is practices who are wanting to have QPIN services offered in their practice, so we got two different entities looking here. One is I want to, I want to be able to get the revenue and not let my
Mhm.
patients slip through the cracks and, improve my metrics. And then another person saying, hey, this looks like this is right up my alley. This is going to get me through the door to use my other credentials that I've got, and because I'm a good fit for this.
Yeah, and you'll really be the hero for your practice if you can present this to them. And feel free, we are more than welcome to do corporate meetings. We have corporate services that we offer. We do auditing services, coding services. So we're happy to advise them on this. The first group that went through, Alicia trained how many in the first group in the QPIN
Oh,
course?
I think it was over 20, and it was
Yeah.
one practice.
Yep. So,
They
we can do it as a live group training.
Mhm.
So just have your practice manager or who's ever in charge, just reach out to us at cco.us. You can email Alicia at cco.us or Laureen at cco.us, and we're happy to work with them.
Yeah. It's really exciting because, they've been talking about, you know, um, MA plans and stuff, helping the patients, and nothing was really ever done or official, and now it actually is. So so many people don't realize that this is a code that's available to them, that when you boil it down, pretty easy to implement, especially if you've already got MAs in your office working. They're ideal in my opinion. And in fact, that's what the one practice did. They were a large practice, but they just got all their MAs trained and to offer these services in addition to the other hats that they wear.
And it's not a long course. It's not like,
Nine
preparing for
modules.
CPC. Yeah. So how long did your 20 take to go through it?
I think they did it in 3 weeks, but that's because the they paid for it. There are people to take it. You could do it in a couple weeks.
Yeah.
Now, if you are not a you have no medical background at all, and this is alien to you, I would give it more time. But we don't now. This is our course. There are courses out there that are really, really long because they teach you, anatomy and physiology. There's nothing that's a QPIN or patient illness navigator, but other courses like that are going to give you all that background information. We're saying no, we've whittled it down. This is what you need to provide this service. It's your responsibility to go get that other education and be able to know what, lisinopril is, or Resitropan, or, you know, Prevacid and Prilosec. What's the difference? Things like that. Uh, that way we made it affordable and straightforward.
Very good. Good job, Alicia. Thank you so much.
You guys, this is
And for those that are on the StreamYard, I provided the how to get the CEU information. A couple people already said that they got it, so it is working. You do have to register at the cco.us site when you click on login. And if you haven't done that previously, then you'll have to register first. It's free. It doesn't take long, but if it is jammed up because a lot are trying to do it all at once, then try first thing in the morning. We
Mhm.
will leave the CEU up with the passcode working until 12 noon tomorrow. So don't panic. We have a help desk. They're not working right now, but they will be in the morning, and they'll look at your emails and get you straightened out.
I'd like to leave you guys with another thought as I put the slide back up about the topic request. The 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 reason this credential was created was because a health system came to us to ask questions and wanted to know if we could provide education. If you know of something that you feel like you need or your practice needs, uh, give us a heads up. We are more than happy to develop a practice or a training to
Yeah.
meet your needs, because if you need it, somebody else probably does too. And that's what we do we're into education. So it's passion. It makes us better as well as hopefully provide a
Yeah,
unique service.
that's a really good point, because if your practice you're working for has a need and you're like, I wish we knew more about this, and we need to do research and have someone present it to us. Well, just ask us. We'll do it. We're very good at researching
Lunch and
stuff.
learns.
Yeah,
We do presentations a lot, and we can gear them. And you know what? You might be the birth of another credential.
there you go. One more question. Once you receive the QPIN, do you have to maintain CEUs for the certification? No, not currently.
Not at this time. No.
Yeah, it's just more, it's kind of the stuff that Alicia was sharing, like in the scenarios. Like once you know how to do that, it's just a part of you.
Yes,
You know.
and this is the QPIN credential is it's not part of a broader I had it just on the tip of my tongue. I was very eloquent in my little gray cells, and then they slipped out. But again, that's not the purpose of the QPIN. The CEUs may be necessary in the future, but it is not at this time. The code requires training, a trained person. It doesn't tell what the training has to be, how much training, but it needs validation. And that's why we created the credential, to prove that you have been trained. And we give you a certificate that you can show them that, nope, I'm offering this service. And look, we have trained our staff to do it.
Oh, and we have a giveaway for one person to take the course for free. And Catherine Headley, you are the winner. So you get to take the QPIN course for free. And
Oh, my word. Catherine asked lots and lots of questions.
that's why she won. So, tell your friends, and, we do on our webinars giveaways every month. And, if you're on in January, and we'll have a free giveaway. And normally we let you pick a ancillary course. This is now one of our many ancillary courses that you can choose from, or a Blitz review class. So spread the word.
Just real quick, these are some of the hottest, the ones that I put on here, hottest ancillary courses. Well, QPIN, but pharmacology, pathophysiology, and medical terminology and anatomy. They're the hot ones. All right, guys. Thank you so much for joining us.
Great audience.
Remember, you can tap into the forum and ask questions, and we're there to answer them for you.
Yep. Thanks for your attention. See you next month, hopefully.
Bye,
Bye,
guys.
everyone.